I'm Dr. Krashen from the Harvard Review of Psychiatry. I'm filling in for Dr. Rom today, doing introductions because this speaker is my wife. And I'm an expert at Dr. Mordova.
That's great.
Dr. Mordova received a medical degree from Comenius University in Czechoslovakia, and she's dual board certified in both internal medicine and neurology. And she completed a headache fellowship at the University of Washington and has been an attending physician at University of Washington Headache Clinic since 2006. She's very active in the education of residents and fellows in the medicine, neurology, and pain departments, and leads an outreach project to educate outside providers about headache medicine. She's also a co-sponsor of the Seattle Headache Support Group and gives lectures to the general public about headaches and chronic pain. She's active in research about the areas of aspirin resistance in headache, the role of patent formin ovala in headaches, and comorbidities in chronic headache. And she's going to give a talk today about the migraine brain.
Okay. Thank you. The introduction. So as you heard, there's an expert on me too. So now. I want this to be completely formal. So I mean, if you have questions, you can decide when is a good time, to ask. And I don't claim to be an expert, in headaches. However, I have seen over 40,000 patients in my lifetime, and out of those, at least 20,000 patients who have headaches. So that's kind of my why I want to speak and why I'm passionate about this subject. So here is my info if someone wants to reach me by email, phone number, So, the talk overview, it's not going to be just migraine, but migraine is the headache that I'm most passionate about because I see most of the patients that I see are migraineurs. However, I treat all kinds of headaches. Coming to headaches, so why would you even want to see a physician? I mean, headaches are extremely common. More than 90% of people suffer from headaches, and most of the headaches are almost always benign. So the most common type of headache is called tension type headache. It's you can see it's type because you don't have to have tension. And as we speak, more than 50% of the people in the world suffer from this type of headache. And maybe many of you here today, as you are listening to my talk, are also having tension type headache. However, the headaches that usually bring patients to doctors are migraines. And migraines, contrary to popular belief, are common and are very disabling. World Health Organization considers them one of the most disabling disorders during the time that you're having migraine. And that's the most common type of headache that we see. And I have a number of residents and fellows who come and rotate with me, and then they come and they say, I hate to tell you this, but I really don't like patients with headaches, and I say, well, I mean, that's why you're here, to learn to love patients with headaches, and don't look for, that's why I have the zebra there. Don't look just for zebras. If you get just excited about pheochromocytoma that you'll never see in your lifetime and continue looking for that, it's not going to be too much fun for you. But if you learn to listen to the patients with headaches and be able to diagnose them and treat them, you're going to have fun every single day you practice, because there's not a field that I know in medicine where you're not going to have a patient with headache. Now, so how common are migraines? So this is an underestimate, but I think 30 to 60 million Americans alone have migraines. 23 million experience severe migraine headaches, and 20% of women, 7% of men. So people always say, is it the hormones? Well, that's part of the story, but not the whole story. Now, what is alarming is 45 million Americans suffer from chronic headaches, and the biggest category that is rising is daily headaches. There's more than 15 million Americans that have chronic daily headaches. And if you look at consultations, 8 million consultations with physicians every year. If you look at ER visits, 3 million ER visits every year are migraines. So migraines are common worldwide, but what is really interesting, so the first number is percentages expressed in females, the second in males, and when you start noticing this, you'll notice that it's, guess what? Not the developing countries, developed countries, okay? So leaders are Canada, States, Europe, Japan, and now I've talked to a lot of my Indian friends. They said, guess what? We're starting to see migraines too, because of the lifestyle has a lot to do with it, but it's not the only part, so I'll talk a little bit more about why people get into migraines. Now, when do they start hitting people? Well, they can start as early as 4 or 5 years of age if people have strong genetic predisposition. However, in majority of the people, then hit them when they're most productive. So in their early 20s, and then they continue on, and as people are retiring later now, I'll have a lot of people in their 70s, their 75, 80, and say, this is ridiculous, I don't have menopause, or I'm menopausal, I don't have periods anymore, how come I'm having migraines, right? You have to do something about this, and so unfortunately, these numbers are from 1993. We redid this. It's probably going to be shifted, further. But and this is the irony that when you're most productive, you're most disabled. So, what does the prevalence of migraine tell us? So the lifetime cumulative incidence of migraines: 43% of women, 18% of men. So it's extremely prevalent, right? So it's something where it's very, very close to normal, if at all it is to be considered a disorder. I'll talk to you about what I think about this. Now, how do you diagnose a migraine? And this is very frustrating for a number of people when they first come to see me, is patient story. So you don't have any specific test that will tell you if you have a migraine or not. And we use these artificial criteria that were developed by International Headache Society. Now, all the people do not fit in nicely designed boxes, but typically, if a patient has had more than 5 attacks, and why this is so you don't miss someone who had first-time headache and has a subarachnoid or something else happening, right, or tumor. Headache attacks usually last 4 to 72 hours, but we have many people who are now getting into chronic migraines that can last ongoingly for days to months to years. The headaches have to have at least 2 following. So unilateral, even though migraine means one-sided headache, it turns out only about 60% of people will have unilateral headache, 40% bilateral, kids usually bilateral. Pulsatile or throbbing quality, people ask, what does that mean? It's kind of like you're feeling your pulse, so it goes in and out. And again, that's only 60% of patients. Other patients will say, no, it's just pressure. And it's usually moderate to severe pain, aggravated by routine physical activity. And during the attack, you have to have at least one. These are considered migraine features, either nausea or vomiting, light or sound sensitivity. Now, so the question that I always ask my residents is, if you had one question to ask a person and you want to determine what is the headache that they're suffering with, what do you think it would be? And they say, oh, unilateral, or, it's a pulsatile. And actually, the one question that you would ask yourself, if you want to ask yourself right now, am I experiencing migraine? Maybe the headaches that I have been thinking are just tension type, maybe I'm having migraine. So you would ask yourself, what do I prefer to do when I have the headache? And if you say, you know what, I prefer to go to bed, lay down, prefer to turn off, all the radio, TV, draw the shades because, I really feel that all the lights, sounds, everything around me bothers me, very likely a migraine, okay? And in kids, you can just infer from their behavior if they, just kind of are quiet and lay down. If you have a patient with cluster type headache, they'll say, I can't lay down. I have to move around. I'm restless. It's that hypothalamic overactivation. On the other hand, for the tension type headaches, people usually do not have to change their activity. They can continue doing whatever they're doing. Now, there are some camps of neurologists who do not ascribe to tension type headaches and believe that everything is migraine, just different degrees. On the other hand, you could argue that in patients who do experience migraines, that they don't have multiple types of headaches, that most likely they do have migraines in different severity. Depends how you look at it. I mean, and I go case by case. Again, I try not to put all the people into the same category. Now, so again, the criteria. Aura, you might have heard of. So aura is a neurological symptom that develops gradually over a few minutes and can represent visual disturbance. Typically, people will say, okay, I'm starting to feel like I'm losing vision on one side, and even if I close my eyes, the vision is still abnormal, and then it gradually progresses. And most people will take 30 minutes, and typically will proceed before headache, but it can occur during headache as well. And some people can have prolonged aura, which lasts much more than 30 minutes. I had a lady who had aura for 3 days with visual loss. It turns out aura is present only in about 20% of people who have migraines. So it's not mean. A lot of people will come and say, my doctor said I don't have migraines because I don't have the aura. Well, what do you do during your headache? Well, I have to stop doing everything. I can't concentrate. I have to lay down. I feel like throwing up. Well, you have migraine. You don't have the aura. The most common type of migraine is without aura. Now, on more rare occasions, you'll have patients who will have aura that can present as one-sided numbness, one-sided weakness, even inability to speak. And this is where you have to be careful, because even though no one talks about it very much, most people will think that, okay, migraine is just pain. It's not just pain, it's brain dysfunction. So during migraine, all the patients will experience inability to concentrate. They have more difficulty processing language. That's part of normal migraine. That's not the aura part. Now coming to why do people get migraines and headaches? Well, so we can't choose our parents, right? So genetics, thank you, mom and dad. 80% of people with migraines will have a family member with migraines. However, that's not the whole story. Environmental factors play an enormous role. Although family and twin studies show that there is genetic component to migraines, there's no gene yet to be found in common forms of disorders. I can tell you this is a very hot field right now. I can tell you what genes they have concentrated on. The only clear genetic basis has been found on migraines, and some people call syndromic migraines. These are very rare, very unusual type of disorders where people have a complete one-sided hemiplegia that looks like stroke. They might have other symptoms too, like ataxia. This is very rare, and in those families, you do find that they have channel mutations. So far, the channel mutations that have been identified included voltage-gated calcium channel mutations on chromosome 19. There are mutations on ATPase, coding for sodium-potassium pump. There have been some other mutations that are coming up, but this does not represent majority of the migraines that we're seeing. And so one of the things that is coming clear that what we identify as migraine is kind of the final pathway. Can happen for a number of different reasons. It can happen for underlying genetic reasons of channel changes. In other people, it's going to be some other genetic changes, but there are people who probably never ever would have had migraines, but let's say they have trauma, or they have something else that changes how the brain operates and will lead them. Like today, I saw a gentleman, he's 39, very productive, works at Microsoft, never had headaches until a brain trauma, and now has them once a week, doesn't have them every day. And usually he acts like a migraineur, and now I'll talk about that. So so genetic factors in migraine, so strong familial association, of migraine with aura, and again the Mendelian migraine, the autosomal dominant, inheritance. That's very small percentage of cases, and although migraine we think is much more complex, multifactorial disorders. So you have probably heard of epigenetics. So that's again the new, right, hot field of studying how does the environment change not DNA but change RNA, histones, by different chemical processes, whether it's methylation and so on. And it's now thought, if you talk to people who have been doing headaches for a long time, that epigenetics may make a large part of the non-genetic factors influencing the presentation. And what it goes beyond things like what we didn't realize: lifestyle has epigenetic changes, nutrition epigenetic changes, medications you use epigenetic changes. So again, this is no one has identified the epigenetic factors in people with primary headaches, but this is where it's definitely going to go as far as research. Now, so this is another question that I usually ask my residents, and is dilation of blood vessels critical mechanism for migraine? And there is not a right or wrong, whenever you have questions where there is a lot of discussion, come to the conclusion. But the current thinking is that it's not a major mechanism that is important for a migraine. So if you say, why not? Well, so headaches can be evoked by stimulation of specific areas of the brain. Headaches can be evoked by lesions or electrodes in the periaqueductal brainstem in the absence of vasodilation. Headache can also be evoked by stimulation of other parts of the what is called pain matrix. So most of the brain is supposed to be insensate to pain. You've heard it. And there are only parts of the brain that are supposedly feel pain, such as insular cortex, and again in the absence of vascular changes. And so this is leading to where again the main interest is always on the pain, but if you talk to thousands of these patients who have migraines, they'll tell you that they'll feel off before the headache starts, right? They'll know something is off. And only now with recent advances, of functional imaging, such as PET scans, functional MRIs, are showing that there are activation of multiple areas of the region of the brain preceding the pain. So the changing concept of migraine is that migraine is primarily a disorder of the brain excitability. And I don't like the word disorder because to me, again, it's such a common, prevalent thing happening that I would maybe argue that is it really a disorder or is it just different operational functioning, of the brain? And vasodilation may occur as part of the disorder, but it's definitely not required for migraine pain. So vasoconstriction is not a primary mechanism of acute migraine treatment. Now, so where does the migraine start then? Excellent question. So whenever you have all of the above, you can choose all of the above. You won't be probably wrong, right? But so where is it? Cortex, brainstem, hypothalamus, and now indication is probably everywhere. Now, so people usually will have multiple symptoms. There is more to migraine than pain. Most people will have something called promonitory symptoms that include fatigue, yawning, mood changes. They can occur hours to days before the headache begins. They can have visual changes, sensory and language symptoms. They'll say, can't concentrate. I'm not able to, I'm hearing people around me, but I'm just not able to process this as well. I can't remember things as well, and a lot of people will have that stomach dysfunction, nausea, vomiting, and very frequently dizziness. And each of these migraine symptoms may occur in isolation or combination, and it can change from attack to attack. In children, the abdominal system is much more sensitive. And if you think about it, where is the second largest nervous system in our body located? The stomach. So that explains it. So the PET, and I'm not an expert in PET, this is an area that I'm interested in, but I'm not going to claim expertise. It does show that there is changes in migraine patients without aura. So the main thing, though, where it becomes very tricky, if you go from center to center that has done the PET studies, they have different areas that are coming up. So and it might be in our interpretation of the PET scans. I think we're kind of too early to really understand what does it all mean. But and the other trick here is that it's very difficult to get patients with spontaneous migraines into PET scanners. So usually these are induced migraines, and you could say, well, is it the same thing, as a spontaneous migraine? And that's a good question. So, but this is activation in migraine patients during a glycerol trinitrate trigger migraine attack when compared to matched controls who were administered the glycerol trinitrate, and what you can see is that there are changes in the activation of pons, insula, and interestingly enough, there is activation usually of the ipsilateral pons in patients with right-sided attack and left-sided attack. So actually the side of the change will correlate to where you experience your migraine. From other studies, there was activation. This is activation during migraine attack before sumatriptan. And again, you can see, there are changes in the similar areas of the brain now. And then I had another study that was showing that they had more hypothalamic, changes. But most of the PET scans, it was either hypothalamus or pons, initial changes, but also other changes such as insula and so on. Now, so how do I think of migraines? Well, currently the consensus is that probably at a baseline in migraineurs, there is a change of operation of the neurons. Currently, most people think of it as increased neuronal excitability, baseline through different mechanisms. When you overexceed a certain threshold, certain equilibrium, like I talk to my patients, using up their brain energy. So people will typically say, okay, I was sleep deprived, I'll go to at the triggers, I'll talk about the triggers in a little bit, but typically when they cumulatively do everything to drain themselves, so, I'll have a lot of residents post-call, young physicians who are starting, post-medical, students and say, I never had that many headaches, now every time I'm post-call, I get significant headache, and so it's extreme stress, dehydration, hunger, and so on, that can all lead to kind of using up, your energy, impairing the homeostasis. That's another term that is frequently used. And once you impair it, you have that alarm system, so you'll start having cortical spreading depression. Current understanding, again, this is very difficult to explain what exactly happens during cortical spreading depression, but current understanding is that your neurons get fatigued, they're unable to absorb all the nutrients anymore, and you get shut down of the brain, which then triggers activation of the alarm system, which is trigeminal nerve. Trigeminal nerve, by the way, is not the only nerve only for migraines. Any primary headache can target the last part the same way, and then you can or may not have inflammation, vessel dilation. Those are not critical for experiencing migraine. So again, increased neuronal excitability. This is an artistic depiction of if someone had, let's say, the familial hemiplegic migraine with a mutation on chromosome 19, they have calcium dysfunction, they again get into disequilibrium, induce the cortical spreading depression that activates the alarm system, activates the trigeminal nerve that then causes the pain. But during the cortical spreading depression, that's when the patients will experience the aura and will experience the inability to concentrate, the inability to think, and other symptoms. So again, this is from Dr. Goldsby, this picture. Brain is insensate to pain, so we think that's a pain matrix that has a lot to do with activation of the final alarm system. Why I have this picture here is because that green loop, it's pterigopalatin ganglion parasympathetic activation. So in migraineurs, you'll have not only trigeminal nerve activation, which is responsible for feeling the extreme unilateral pain, but you will also have nasal congestion, watery eyes, and there are more than 50% of people who think that they have sinus headaches that are not sinus headaches, they're migraines. Because this is the same nerve that will give you the sinus headache. However, for a sinus headache, now by definition you have to have fever and mucopurulent discharge. If you don't have that, very unlikely that you have sinus headaches. And what I have done, a number of the patients that were sent to me by ENT, they go to ENT, they say, I have severe sinus headaches. They do CAT scans of their sinuses, they're clear, and they're sent to me and they have migraines. So this is kind of the change, but I'm explaining why this is. So this is from Dr. Dodig, who is current American Headache Society president. Is kind of simplistic, picture because it doesn't go 1, 2, 3, 4. And probably our brain, is much more complex than that. But you have cortical spreading depression that you activated once you change the homeostasis or threshold. This then activates your alarm system. Trigeminal nerve activates your thalamus, and the thalamus executive secretary, again, simplistic, right? Decides whether or not to give you the headache. And his point is, if people are stressed, depressed, that it's much more likely to decrease, to activate the cortical spreading depression. I would say, well, it's not only depression or stress, it's anything that depletes you can activate the system very easily. Now, and the trigeminal nerve says usually the first branch of the trigeminal nerve that is activated during primary headaches. So this is the same nerve that will be activated in migraine, the same nerve activated in tension type headache, the same nerve activated in cluster type headache. In trigeminal neuralgia, it's usually second or third branch. And then what happens, so as you go to the cascade, you start at the trigeminal nerve activation, you can have vasodilation, neuropeptide release, but it's not the first and the most crucial part of the migraine. So what are typical migraine triggers? And when you talk to people, a lot of times they'll say, I don't know, because sometimes it's sleep deprivation, sometimes it's weather changes, sometimes it's stress. And once you start thinking about it, it's cumulatively everything. Foods have a lot to do with it, and I'll tell you about some of the foods that are mentioned by migraineurs. But what I tell people, okay, add all of these up, put a line and, add them together. For most migraineurs, it will be at least 7 triggers at the same time. However, if any of these one triggers is powerful enough, it can push you over. So if you have an extremely stressful situation, like I have a lot of people who complain about their bosses, right? And then I, say you need to talk to your boss that you have migraines and they shouldn't stress you out. They say, can you write a letter, right? Or change your job, right? My partner, I don't usually say it, will say, okay, if it's your spouse, why don't you just get rid of them? I don't usually say that, but, hormonal cycle, sleep deprivation, so everything adds up. So caffeine, so I'm not anti-caffeine. I mean, this is Seattle, right? Starbucks would go after me. But what I'll tell my patients is, okay, depends on the amount. If you have a cup of coffee every day, probably okay, but if you're using it to increase your energy, probably not a smart idea because it will use up your energy. You better build the energy in some other way. Don't use shortcuts all the time, right? Have coffee when you can enjoy yourself and when you feel relaxed with your friends. Don't use it as a stimulant. If you want to get rid of your 5 cups of coffee a day, don't do it at once after this lecture because you'll have a rebound headache. Do it by half a cup every 3 days. Now, chocolate, and kind of joke, but it's actually serious. It's not theobromine as far as we know. It's the additives, so cheap chocolates. I tell my patients, avoid the cheap chocolate, buy the good stuff, the dark chocolate. Tyramine, it's a bad picture, but any aged food will accumulate tyramine. It's degradation of food. It is one of the chemicals that can definitely trigger migraines. They say, why? What is the current thinking? Any small molecule that can likely bypass the blood-brain barrier and overexcite neurons can likely push people into migraines. So nitrites is another one. So don't eat your dogs, again, additives to meats. MSG, is very popular, right? Because after the Second World War, food was scarce, right? And it tasted horrible. And so Japanese invented MSG that was bought by states in the 70s, right? And now it's in all the foods, and MSG will definitely increase the likelihood of having migraines. It's definitely anything that is excitotoxic or increases excitability of the neurons. Alcohol, people always ask me, can I have, I had one patient who I got out of headaches, and then he emailed me and said, Dr. Moreno, but now I drank a whole bottle of wine by myself and I didn't get a headache. And I said, well, that was not exactly the idea, to get you. And he said, well, I was just trying to see if I could get headaches again. I said, well, we don't want to do that. But what you want to do is actually additives from what we know. So what I always recommend, if you have anything, first of all, try it because it's not quote unquote all red wine, but sulfites, nitrites, additives. So there are tons of organic wines that claim they don't have it, but try them first. And then have it with a glass of ice water or 2. Some of the migraine experts proclaim that you should be drinking pure alcohol without any colors. But to me, like, okay, a lot of things are flavored and there are a lot of things added, so I wouldn't subscribe to it. And fatty acids. Now, so normal menstrual cycle looks like this, and we say, why am I talking about it? Initially, I told you that women are more likely to have migraines or any pain compared to men. This is real. And if you say why, well, the current theory, this is from Vince Martin, is that when the estrogen dips, that's what causes the migraine, and he can postpone it if he can postpone the dip in estrogen. However, it's more complicated than that. So this is from, you can't see it really well, but on the last column from Vince Martin, it says, when you have that dip, you will have decrease in serotonin, you will have decrease in magnesium, you'll have increase in prostaglandins, you'll have decreased adrenergic tone. So it's what we kind of, how we think about it is that what happens when the estrogen decreases, your serotonin decreases. And as you know, serotonin is one of the major chemicals that is not used just in depression, but in pain, that can definitely decrease pain. So during that time, so I saw today a 21-year-old patient who was a graduate student at UW, and she said, good news, I'm out of my daily headaches, but I get now one headache a month. And guess when it is? I said, menstrual period? And she said, how did you know? You're brilliant. Well, I'm not brilliant, but it's menstrual periods are very, very strong trigger of very severe pain, not just migraines, any pains. Now, so what are the mechanisms of treatment? And I'm not going to aspire to have you all become, migraine treatment experts. I'm just going to briefly talk about the mechanisms. So the main medication that is used in states, or main group of medications are triptans. Now, all triptans they address the last part of the migraine. So they address what I call the alarm of the migraine, the trigeminal nerve, and potentially the vasodilation. They do not fix the brain. Okay, so when you have shutdown of your brain and you take a triptan, you will take away the alarm. You won't feel the pain, but you will not feel normal. You'll feel very abnormal. You'll feel like you can still not concentrate. You'll still not yourself. And you say, you know what, it's the triptans. No, it's not the triptans. Take the triptans when you don't have the migraine. You won't experience it. So what you're uncovering the shutdown of the brain. And the more pronounced, the more you push yourself to shut your brain, the more factors played into it, the more difficult it is to get out of it. So, the prevention is really the best thing. So if you say, how do I look at it then, and how should migraines be treated? Well, if someone is having more than 5 migraine days a month, then I always recommend preventive treatment. And it's not necessarily just medications, depends on the situation, but it might be, okay, addressing, are you sleeping enough, what is your sleep hygiene, daily exercise, nutrition, stress reduction, behavioral changes, and addressing, it turns out that it's not that migraineurs have more stress around them, but they perceive the life as more stressful, but you can retrain yourself. And I think that's crucial, and pace yourself and not use all your energy till you have none and then you have a headache and then you want a triptan to fix it. You won't fix it, you can use it occasionally, as a shortcut, but it will not work in the long term. Now, what are the prophylactic treatments we use? We use everything from beta blockers, calcium channel blockers, antidepressants, anti-epileptics. And if you say, how do they likely work? Well, that's a very good question. The current thinking is that you're somehow changing the operational system, right, of the brain. And as you know, we used to think that, antidepressants, quote unquote, change, serotonin, increase it, decrease it, and now it's more fashionable to say modulating your serotonin, right? Because who knows what we're doing. So beta blockers are very interesting because there are a number of patients who turn out to have low COMT levels, catechol-methyltransferase, and it turns out that those people, if they get under stress situations, cannot get rid of their adrenaline. But beta blockers help treat chronic migraines in those situations. And also behavioral therapy, biofeedback, all kinds of things like this. Anti-seizure medications obviously work through multiple of the receptors in decreasing pain. And for acute, triptans, NSAIDs, anti-nausea, but to me, again, the main goal is to reduce the headaches from happening, not just, treating acute migraines. Now, so definitely multidisciplinary approach. So always managing comorbid psychiatric disorders. And what I see in my practice, I see a number of patients who, when they're in the daily migraines, they're overdiagnosed with a number of psychiatric illnesses. And maybe they do have the symptoms, But once they get better and out of those cycles of daily pain, they're not having any issues anymore. So it always makes me think, what is the connection? I'll tell you what I kind of think. So pain psychology, physical therapy, I always believe in movement, trying to increase your energy, build your muscle, nutrition, eating real food, avoiding edible-like substances, right, or immortal edible-like substances like Twinkies, and whatever. Sometimes we do use, anesthesia pain medicine. To me, sometimes if you can get a little bridge towards decreasing your pain, so then you can do more to fix your life, that can be worthwhile. So whatever we can do, right, to get people better, is all worthwhile. And conquering headaches. And so the question is, if you say, why do I do this? Because I kind of feel that if I can help the people, that I can bring them back to their families, to society, and back to work and doing things that are worthwhile for them. Now, one of the things that I don't have on the PowerPoint, which is a whole different talk there I have, is comorbidities. And since this, a lot of you here, right, work in psychiatry, that's right here, there is an incredible comorbidity of anxiety and depression in migraineurs. And it turns out if you can address those, you can help, the migraines. But I don't see it as, just relax. It's not as simple as that. I think it's much more complex, and again, whatever we can do, to help ourselves and our patients, I think is all worthwhile. So I'll take questions. Any questions? Okay, Dr. Avery has a question.
Yeah, could you describe in more detail the spreading cortical depression? What does that look like on the EEG?
So not, so it was documented not on EEGs and functional imaging. So they had functional MRI. I don't know how it looks like on the EEG, but functional MRIs and PET scans. And basically, the main mediums that were used, was oxygen. So I haven't seen this redone with other tracers. That would be the interesting thing. But what you see is reduced uptake, of oxygen in the areas where it starts. Now, cortical spreading depression and Dan can give you those studies, have been now documented or seen in live people who had brain trauma where they had actually open skull. So that's how they put directly, the monitors on the brain and recorded it. But I can give you those articles. Go ahead, there's another question.
In people with refractory headaches, or even in general, are there any treatment protocols that have been recommended in terms of the sequence of trying things or predictions, like if this class doesn't work, switch to another class? So I'm just curious about how you approach that,
Okay.
even though if you can't go into detail. Just
Sure. So the question is, how do you approach chronic daily headaches or chronic migraines? So the chronic migraine is defined as having more than 15 headache days a month. And in majority of the patients that you meet, you have to first identify how did they get into it. Was there a trauma? Was there something else happening? Because you would want to always rule out first a secondary disorder, right? Making sure that, their MRI and so on is normal. Now, if it's normal, then your next question is going to be, how are you treating them right now, right? And what you're trying to identify is any acute pain medications, even benign over-the-counter things like Tylenol, etc., and ibuprofen, and any prescription medications such as opioids, because migraineurs are a very small subgroup of patients that are very prone to developing daily headaches with medication overuse. So what happens, what we currently think, is if you start taking, let's say you're a migraineur and you start taking Tylenol, etc., more than typically once a week, you start inducing hypofunction of multiple pain operating parts of your brain, specifically thalamus, orbitofrontal cortex, insula, and so on. It's reversible. It's completely reversible. The unfortunate thing with the brain is that any changes that you want to see, if you start doing everything correctly today, it will take you at least 6 to 8 weeks to see the results. So I typically have my follow-ups, spaced out 3 months later, and by that time, majority of the patients, if it's simple medication overuse headaches, they'll get dramatically better. Now, if it's someone who's had daily migraines for 38 years, I saw a patient like that for follow-up last week. She saw over 15 neurologists. She is currently headache-free. But if you say, what approach did I take? Well, she was taking daily medication, saying that that was really not the cause of her headaches because other physicians have tried. Well, but I didn't recommend only taking off the medications. I really recommended a daily exercise program, changing her nutrition, addressing sleep, addressing stressors. And so you need to do more than medications. I think that anytime you deal with brain dysfunction, medications are not enough. It doesn't matter if it's depression, anxiety, or pain. If you try to do it only via medications, I think you can help people maybe 20%, but sooner or later the brain will adjust, and you're back in square one. And I think that's why there are so many people who are in chronic pain, because they go from doctor to doctor and just get a new prescription. That's kind of how I see it. Okay, another question?
Do you see those daily headaches with the triptans as well? Do you see the overuse headaches with the triptans?
So the question is, do I see daily overuse with triptans? Absolutely. So if you start taking triptans more than 6 days a month and you have susceptible brain, you'll get daily headaches, absolutely.
So Botox is no longer used at all?
So the Botox question, can you use Botox? You can use Botox. It's FDA approved for treatment of chronic migraines, more than 15 migraines a month. It was FDA approved in May of 2010. However, long-term, it doesn't solve. I have used it as a bridge for many patients who were, let's say, overusing opioids, where it was very difficult for them to get off. I have one lady now, she's headache-free, has been on opioids over 20 years with daily migraines. So I use it more as a bridge. To me, it's not an end-all solution, because then if you just rely on Botox, yes, Botox will decrease your pain, but then within 2 months, you're back at square one. And you need to have the Botox again. And, so if you solely rely on Botox, I don't think that that's going to solve it. It can be very good initial, treatment. But to me, if I don't have to go there, I believe in independence of patients from physicians, not dependence. So I have many patients who have seen me only once or twice, and then, I can, sometimes see them later, something happens, or, someone calls me. But if people follow kind of all the recommendations, like I can tell you, I've seen before I came here, I saw 5 follow-up patients and 1 new patient, and all of the 5 follow-ups were headache-free. Okay? So, and all of them came to me with daily migraines. Go ahead.
I'm just curious about this withdrawal from drug question some more. Opiates and nonsteroidals are so different in the mechanism of action. And 20 years ago, nonsteroidals were used a lot for migraines, and now I guess they're not. So I'm wondering, is there a unified mechanism or way of understanding that? Because I don't see exactly how that fits into the metabolic cortical story that well. I'm just wondering if there's more known about that. It's just really interesting.
Can you rephrase your question again so I understand it better? And
Well,
then I'll repeat it.
people use nonsteroidals, let's say naproxen, and then if they use it too often, I'm understanding that can make them prone to withdrawal headaches. And the opiates have a very different mechanism of action. And I don't understand where they cross over so that they would have a similar effect on headaches. They seem so different. And I'm wondering if that's understood well.
So the question is, how well is it understood why different medications, such as nonsteroidals and opioids, can both cause, daily pain. And the current, if you look at the medications that cause it, it's frequency of dosing, interestingly enough. So you're doing something to receptors. You're giving supraphysiologic levels that they're not used to, right? And they're changing somehow how the receptors operate. So even aspirin, if you use baby aspirin a day, you will not get into rebound headaches in the majority of the patients. However, if you start using the aspirin multiple times a day, like I had one patient who was very clever, and I saw him about a year ago. He came with 3 types of headaches. He actually had cluster, migraine, and tension type headache. Got out of the daily headaches, and then he got more stressed about a couple of months ago, and he said, I don't remember you mentioning aspirin. I have been using aspirin 3 times a day. I'm wondering, I'm back in daily headaches. Well, it's a dosing, it's a frequency. Anything that is short-acting is very likely to cause that rebound phenomenon. But what you're doing is somehow changing the operation of, no one knows the detail on the receptor level as far as I know. But that's occurring, understanding. And again, if you say, well, is it epigenetic change, I don't know.
If you have someone taking a non-steroidal
Mm-hmm.
or even an opioid around the clock and you want them to stop it, do you recommend a certain taper?
Mm-hmm. So the question is, what kind of taper would you use, for a person taking non-steroidal around the clock or using opioid around the clock? So there's a very good article from Dr. Stuart Tepper. It's called Breaking the Cycle of Medication Overuse Headaches. There is not one approach. I have to say, that people will say, I'll have patients referred to me by primary care physicians from somewhere from, Spokane, and they'll say, I used your approach, for the next patient because the patient that you saw is now headache-free, and it's not working. I think that, again, it's more than medications that you have to do, and you have to be able to convince the people that they have to do it, because there are many patients who have heard from their physicians before that medications might be an issue, but they didn't get that message through that it's really, really important. So if you say, what are the approaches I have used? I have used low-dose steroids, prednisone, maybe 10 to 20 milligrams a day, for 3 to 4 weeks and then taper off. That's one approach I have used. I have used approach starting pregabalin that kicks in within a week. I have used approaches of, giving them small amounts, of Topamax and other preventive medications. However, the problem is that most preventive medications do not work when your brain is in that dysfunction. They just don't operate. So I have many people who have come and say, I've tried 45 medications before, and they'll show me the whole list. It's true. They have literally seen hundreds of appointments. They'll bring me the whole list. But if they have tried the preventive medications when they were still using the acute medications, it will not work. So this is where it becomes very, very tricky because, and how do you do it? Because if you do it very quickly, people will have, so if it's non-steroidals or Tylenol, they can probably cold turkey it. If it's opioids, probably want to do a taper. But if I'm dealing with, one patient who's now in Kentucky, and the issue is she's using opioids every 2 hours. She has seen 15 neurologists. She asked me how to do the taper. I explained to her, but, so then a week later I get a call, I'm still having pain. And I said, well, how often are you using the opioids? Every 2 hours. But I started taking the prednisone you recommended, and I have started using the needle. Well, it won't work. And I know I'm calling too early. You said that it takes 6 weeks, and it's just a week. But I'm impatient. I have horrible pain. Even if I'm taking opioids, I've been taking 20 pills a day. I still have horrible pain. And so she has seen a number of neurologists who told her that, it's a big issue, right? That she, as a migrainer, got in trouble with medication overuse. But it's very, very difficult in the initial stage, to convince the people that, yes, and sometimes I think people, it's not that people just do it for fun, and I think, again, having the support, having someone, who can be around, to support you, but really believing, that you can, get better. And so I have a lot of the patients that I'm getting right now is that their friend got better, a relative got better, so they believe, that, she did it for them. But, you were talking about the Botox. I had one lady that I did, Botox on, but she didn't institute any of my other changes. She's still 350 pounds, she doesn't exercise. She eats cookies because that's a quality of life, you have to eat cookies every day, right? Otherwise life is horrible. And, and I'm not joking about it, because I try to be compassionate with my patients, right? I try to be understanding. But if you don't institute the other changes, if you don't change the diet, if you don't change your stress levels, then, the prednisone alone will not cut it. Okay. So, Dr. Avery?
Do any of these patients have any seasonal variation in their migraine?
So the question is, do people have seasonal variation in migraine? That's an excellent question, and the answer is yes. But that's anecdotal. That's, because I haven't, targeted, we're going to try to look into this, but December, worst month. December, like December is like, I was thinking like next year I'm taking vacation, for December. Now, it's not like cluster headache, but something, it correlates when the people get admitted, because my colleague did, this is a publicly available information. You can get it from Discovery Park, where they monitor the pressure changes. And it turns out that the spike in seizures are with the pressure changes. And that's exactly when I see the spikes, in the people with headaches. However, I have to tell you that once the people get into excellent control and change their threshold of operation, then the weather doesn't really bother them that much. It's only when they're in that very sensitive stage where the threshold is not very far from getting a headache, then the weather really does matter. So it's not like cluster, where even if they're well controlled, the cluster,
Any variation with latitude?
So variation of latitude. So technically, what I see is, I don't know if latitude, but geographically, Washington, so probably the lack of sun, very significantly influences people. They do much, much better in places like Hawaii, and so on. So there's no question about that. People, I had one patient, not just one, I have, within the last year I had 10 patients who moved. But I had one gentleman with chronic daily migraines, and he took my advice. He was on daily opioids post-stroke, stopped them. And then he had family in Hawaii. He went there, completely headache-free, comes back to Seattle within 24 hours, daily pain.
So then the question is, how many of these folks have winter depression, and has light therapy been used to treat these folks?
I use it. I use light therapy to treat, the people. But I do it in a more sneaky way. I'll say, okay, you need to just go out every day. Even if the weather is horrible, there's more sun outside than indoors, believe me. And they'll say, well, can I just use blue light? I said, you can buy the blue light, but you need to go outside every day. On top of that, if you want, you can use the blue light. And they'll tell you they feel dramatically better. They do. So again, is it the serotonin? Is it the melatonin? Are we doing something else? It would be very interesting, to see. But
so a follow-up to that, studies of circadian rhythms in these individuals?
I have not seen any study of circadian rhythms in migraineurs. So good question. So go ahead. There's another question.
How do you explain convincingly the difference in incidence between poor countries and rich industrialized countries?
Okay, so it's a very good question. How do I convincingly explain the incidence? So incidents, the numbers speak for themselves, so I don't have to explain them. But if you say, is it really real? And I don't know, because as a lot of poor countries, people do not go to physicians unless they think that they're dying. We had just recently a group of physicians coming from Peru and from Vietnam, and they explained to me most people do not have a primary care physician. They do not monitor their blood pressure. They treat everything themselves. So good question. Is it just underreported? Does it not happen? However, if you ask a lot of people who came, let's say I have a lot of patients from Microsoft, and they'll say, none of my family ever had headaches, back home. I came here within the first year, I got very severe headaches. Since it's believed to be very strongly familial, you have to think that there is something, in the environment that we are doing different. And, most of the patients who have migraines, would tell you it's stress, right? That's the workaholism that we institute, on people and pushing them to work harder and harder, and never-ending work hours. It's not like defined work where it used to be 8 to 3 or 8 to 4, right? People work nonstop. But in spite of that, I have many patients who then continue working nonstop, but do much better with headaches. So can I have Senator to say something? We have actually my ex-patient here. If she wants to tell it, because as much as I can tell you, people usually do not trust physicians. They trust real people who had the real issue.
Is sleep hygiene worse in developed countries compared with underdeveloped countries?
So is sleep hygiene worse here than in developing, or the other way around? Where is it? Developed worse? Yeah, I would say in developed it's probably worse than in developing. Yeah, and I would say that probably most of the developed countries spend much more time outside, than we do, right, and are much more physically active. So, it's probably every single thing contributes. Yeah, go ahead.
Yeah, I will speak up. I'm an ex-patient of Dr. Morenova's.
Yeah,
Just saw her one time, and I had migraine.
You should
Had
come to that
migraine.
because there's this.
Past tense. And I did everything she said.
You should go to the speaker.
Yes.
It's,
So I'm a general internist and a professor of epidemiology at the U, and so I thought I knew things. But I finally went to see Dr. Morenova, and she gave me this spiel plus more. And she gave me, I was overusing triptans, just triptans, and just stopped those. And she gave me some steroid and some beta blocker to get over that. That was a frightening thing to stop them because I thought I would just be deluged with headaches. But I got through that sort of couple weeks, 3 weeks, 4 weeks. And then I was just using the beta blockers prophylactically, and then I did the lifestyle things. Well, I started them right away. But I already have pretty good nutrition and sleep, but I work a lot, and I wasn't getting enough exercise and so on. So I did everything, and I read a book that you recommended that talked about diet. I don't drink anything with caffeine anymore. I don't drink any alcohol anymore. But that's worth it because I haven't had a headache in a year and a half now. So, and I don't take any meds now. Nothing. So. I never would have thought that I could be without migraines.
So there you go. That's your answer. Testimonial. Go ahead.
Is there any connection with diet sodas and migraine?
So is there any connection with diet sodas and migraines? So to me, diet soda is not a real food or a real drink. So that's the answer. So get rid of them. It's edible-like substance or edible-like. Go ahead.
My mother suffered severe disabling migraines for many, many years, and with no pathology identified. And they would hit her on the weekend when she was relaxing, and that was always curious to everyone in the family. And she was the type who would, when I say debilitating, violent vomiting, huge aura, all of that. And she went in for surgery for a non-malignant cancer. Following the surgery, she had a migraine again. Have you heard that story?
Yeah. Yeah. So the story was a testimonial that, and I'm sorry, I don't know your name. Dan. So Dan's mother had very disabling, he can attest that it's very disabling to have migraines, right, that she was sick, and she had migraines on the weekends known as letdown headaches. So a lot of migraineurs, unfortunately, will have the headache only, like today, the programmer that I saw from Microsoft, he always has headaches on Saturdays. Not when he works the 80 to 100 hours a week, it's on the Saturday that it hits him. And the letdown headaches, finally your brain realizes, okay, he's not doing anything important anymore. I can let him know that he has no energy left, and I can hit him with the worst headache so he can finally relax, right? And so you spend your, Saturday and Sunday in bed, and then it's time to go to work again, and you feel great, right? Because you have your energy. So then you mentioned that she went for a surgery. Do you know what anesthetic she got? Okay, so there are many anesthetics that can reset the threshold of headaches. So propofol can get people out of daily headaches and daily migraines. It can change your setting, and so if you reset the setting, the threshold of the migraine, and then stopped, overusing whatever you're overusing, very easy way to get out of migraine. The problem is most anesthesiologists will not give people propofol just for their headaches. Because even if it's disabling, it's not something that is approved in states.
Ketamine?
Ketamine, you can probably, people have used ketamine for very severe trigeminal neuralgia to, again, reset, the threshold. But it's not, again, something that is routinely, this would be something within the experimental kind of scenario. It's not something that is considered the standard of care in states. Okay, so, go ahead.
Have you ever noticed a difference in the treatment or prevention of migraines with ORAs versus the migraines without ORAs?
Okay, so the question is migraines with auras versus migraines without aura, treatment. So both of them you approach, the same way, but with migraines with aura you have to be much more careful as far as estrogens, because the aura is considered a potential risk for stroke. So you have to be very, very careful, and these are the patients where you want to do the studies potentially for the patent foramen ovale, doing the brain scans and making sure that they don't have any factors that would increase their stroke risk. You need to really very seriously address that. So those are very rare patients. If you say, how many patients have I had with migraine with aura? Within the last year, out of the thousands of patients that I've seen, maybe 20. It's not very, maybe more, but it's not like, something that I see every day. Okay, go ahead.
You see very many cases, this may not come to you, but patients who have essentially aura without migraine.
So the question is, can you have aura without migraine? Absolutely. What is very interesting is that if the aura is disabling enough, it will stop you doing what you're doing, and it will actually stop the alarm of pain. So if you, during the aura, will stop doing whatever you're doing, you will not get the pain. If you continue doing what you were doing, on the other hand, you can get a very severe headache after aura. But typically aura, a lot of times it will just be aura, not a very significant headache, if a headache at all.
But you treat it the same way?
You treat it the same way, yeah. Okay, so apparently I'm supposed to end, so thank you very much for your time.